Welcome, everyone, and thank you for joining us for another insightful Newborn Toolkit webinar. My name is Dr. Mbozo Sipalo. I am the Knowledge Management Co-Lead of the Newborn Toolkit. Today's webinar will be on mapping and closing gaps in neonatal research, zooming in on implementation, research, and equity. The Newborn Toolkit is a multi-country, multilingual learning platform for small and sick newborn care. Over the last 12 months, we've had over 55,000 unique users from 170 countries. And that's all thanks to our collaborators and implementers all over the world who make use of the Newborn Toolkit. So recently, we've had implementer feedback on what is the Newborn Toolkit. So Robert Taylor, Nest 360 QI lead from Tanzania, shared that the Newborn Toolkit is a supermarket for small and sick newborn care resources. And Dr. Msandeni Chiuma, Ministry of Health, Nest 360 country lead Malawi, defined the Newborn Toolkit as bits and pieces for what you need to make newborn care work. So once again, welcome to this webinar where we'll be covering mapping and closing gaps in neonatal research, zooming in on implementation, research, and equity. So on the screen now, you have QR codes to our newsletter in English, newsletter in French, and our social medias on Twitter or X, LinkedIn, and Facebook. Our host today is Dr. Peter Waiswa, who is an associate professor at Makerere University School of Public Health and Global Health Division, Karolinska Institute, and he's a leader of the Makerere University Maternal and Newborn Center of Excellence. Welcome to our webinar, and over to you, Dr. Peter Waiswa.
Thank you so much, Mbozo. Thank you so much, Mbozo. I'm happy to lead this webinar. In the webinar today, we'll have first we'll have some presentations, 4 presentations, and later a panel. The webinar is 90 minutes, and I'll start by introducing the panelists. Our first panelist, the presenters. Our first presenter is Eva Lokoides, who is Eva is a pediatrician and a clinician scientist in London with research in global maternal newborn child health. And her research focuses on supporting small and vulnerable newborns. Then another presenter is going to be Lorraine Allison. Lorraine Allison is a pediatrician and a neonatal researcher. She's currently based at the London School of Hygiene and Tropical Medicine, and she leads knowledge translation for this new born toolkit with a focus on French. Doris Kwesga is the other presenter. Doris is a postdoc researcher, Ugandan, social scientist, and health systems expert who has done a lot of work over the last 10, 15 years. Her focus is on qualitative research with a lot of interest in institutionalizing community newborn care, especially kangaroo mother care. She does also complex systems approach to drive impactful healthcare changes. And then our lead, Professor Joy Long, who is a Ugandan-born, British-trained pediatrician and a perinatal epidemiologist with over 30 years experience, especially in sub-Saharan Africa. Joy is also the chair of the Lancet Commission on evidence-based implementation. So we are going to start with the first presenter to give us a presentation, which is going to be Eva. Eva, over to you. Eva will give us a presentation on newborn research around the world over the last decade. Where and what are the big gaps in newborn research? Over to Eva. I think Eva has a recording.
Hello, my name is Eva. I'm a pediatrician working in London. A big thanks to the organizers for this opportunity to speak at this webinar. I'm going to be talking about our study that mapped funding for research related to newborns and stillbirths. And this was published in the Lancet Global Health last year. I'm obviously speaking on behalf of our fantastic project team of both clinicians and academics, without which this work would not have been possible. So we set out to conduct a review of research funding related to newborns and stillbirths, and we did so using a database called Dimensions. It's the world's largest research funding database with over 7 million grants. In simple terms, it can be thought of as a database like PubMed, but holding data on research funding, including where it is going to and who it is awarded by. In terms of what was already known, we could not find any similar work mapping research funding in the published literature. So, in discussing with experts, we decided on search terms and Boolean operators that we used then to identify all grants relevant to newborn health and stillbirth research in the Dimensions database. And we set out to conduct this funding analysis with two main objectives, really. Firstly, we considered the big picture of what's happening globally with new research funding commitments over a 2-year period. For feasibility, we looked at major funders identified in the whole database with our newborn or stillbirth terms. And we defined these major funders as those who awarded at least 15 grants worth at least $5 million each, or to include smaller scope but highly active funders, at least 75 grants worth at least $1 million each. Our second objective focused on any funding available over a decade that was given directly to or included at least one research organization in a low or middle income country. We really wanted to hone in on the funding landscape where 98% of the burden lies. After identifying grants that were directly relevant through in-depth content analysis, we then categorized them according to research theme, research type, and we also looked at who the main funders were, as well as where funded research was hosted. This slide just summarizes our flow figure from the paper. As you can see, we reviewed over 10,000 grant titles and abstracts in detail. And in the end, we were left with just over 3,000 included grants for our in-depth analysis for both objectives. In our first objective, we looked at new grants awarded by major funders in 2019 and 2020. And we found that major funders awarded in 550 grants about $557 million on average per year. Of this huge sum, just 40 million or 7% was awarded to institutes and LMICs, where we know 98% of the burden lies. There is thus a significant global geographic burden mismatch here. Of the top 13 funders we had identified, the vast majority were from the United States or Europe. And this table shows you some of the top funders, with the United States NIH very much dominating. Notably, 88% of recipient organizations of this global funding were also based in Northern America or Europe. For our second objective, we looked in detail at a decade's worth of research funding active between 2011 and 2020, and identifying grants that had at least one LMIC recipient. Over these 10 years, we found a total of $484 million actively funded newborn or stillbirth research. This was through close to 2,000 grants, which, as said, each had at least one grant recipient hosted by a LMIC. For context, this total active funding for a 10-year period is less than what we estimated to be the average amount awarded globally by major funders in a single year. This ribbon figure shows how funding flows according to World Bank economic groups for the host country of both the funder on the left and recipient organizations on the right for any one grant. We accounted for the distribution of funding where multiple recipient organizations are named, which is often the case with research grants, and we assumed there to be an even distribution of funds where this was the case. This figure illustrates some important points. We found that more than 80% of funding involving LMIC partners over this time period was actually awarded by high-income country-based organizations. Only 14% by upper middle income and about 2% by lower middle income countries. Of these grants, only 68% of funding, around 330 million, was directly available to LMIC recipients, because nearly a third was co-allocated to recipient organizations in high-income countries. We can see in the purple ribbons that upper middle-income economies funded nearly 69 million to others in the same economic group, which is more than they received from high-income countries. Notably, very few grants had research partners in the lowest income countries. Displayed here are some of the top funders in this 10-year data set of active grants with at least one LMIC recipient. You can see the Bill and Melinda Gates Foundation as top funder, followed by the European Union and the UK government's UKRI. However, note also China, Brazil and South Africa featured in the top 10. This map shows the destination of all these grants, which again, I remind you, all had at least one LMIC recipient. Countries in the darkest shade of red represent countries with the highest number of active grants. Note China and Brazil. The bubbles here highlight the 5 top recipient countries according to this number of grants received, but the bubble size represents the total 10-year amount received in those grants. Note that the UK appears as a major recipient of research funding with LMIC partners, but BRICS nations are otherwise key leaders here. Considering this together with the ribbon flow, I hope another major gap is apparent. About a third of global research funding to LMICs is being co-held by high-income countries, and we need a shift to truly LMIC-led research. Over the 10-year period, the yearly active funding from grants with at least one LMIC recipient almost tripled from 23 to 68 million, as shown in this bar chart. Research themes receiving the most funding were neonatal infections and complications of preterm birth. However, a major mismatch was that only 2.5% was awarded to research focused on stillbirths, despite there being a similar number of annual stillbirths compared to neonatal deaths. So another gap here, with research topic maybe not always commensurate to burden, and this is striking for stillbirths in particular. In terms of the research pipeline, nearly half of all funding went towards basic science or discovery, with 20% for interventional research and implementation, including complex evaluations and health systems research, receiving less than 3%. So another gap here, relating to disparities in funding by research type, especially regarding implementation research. So putting this all together, what we found was that there is a lot of money being invested. We estimated globally $577 million are newly awarded per year by major funders. And over a decade, about $485 million actively funded research with LMIC partners. However, there are notable gaps in where and how this money is invested. There's a geographic burden mismatch, and there's a need for research leadership transition to LMICs. There are certain neglected research topics, notably stillbirths, and there's a big gap in funding of implementation research. It is encouraging that total yearly amount of active research fundings have been increasing, and that BRICS nations are stepping into leading roles. However, clearly there's a need for not just more money, but more targeted and fairer spending to maximize the impact of all newborn health and stillbirth-related research. This is why the Newborn Toolkit research funding map has been created. We hope that visualization of the data I showed you today will increase transparency and accountability regarding global newborn research funding flows. In addition, hopefully the map creates awareness of research activities and can help support collaboration and uptake of research findings from the current limited funding available for newborn research in LMIC settings. I will now hand over to the next speaker to tell you more about this exciting initiative, which I very much hope will help us all go faster and close these gaps.
Thank you so much, Eva, for that presentation, which is about where the funding goes. Now we are going to go to our second presenter. Lorraine is going to show us this map and also launch it. Lorraine?
Thank you so much, Peter and Doris. So I think Doris gave a really fantastic overview on how you can use the map from the perspective of a researcher. So I'll just kind of give a brief overview of the map and some practicalities of how you can use it. So this map, it was created because only 7% of newborn research funding is allocated to low and middle income countries, despite representing 98% of neonatal mortality burden. We really wanted to reflect this, and this was done using the data set from the research funding analysis that Eva discussed in her first talk today. So it includes all the grants with at least one collaborating recipient based in a low and middle income country, classified by the World Bank. Next slide, please. So each grant on the map is linked to a grant card, and on that grant card you can find the title of the grant, the year that the grant is running between, the theme, so in this case it's neonatal infections, the country in which the grant is allocated towards, the funder, so here it's the European and Developing Countries Clinical Trials Partnership, and then the collaborating recipient institutions are also listed, and the type of research in the research pipeline. So in this case, it would be observational research highlighted in purple. And then within the map, you are able to filter according to different criteria. So if you want to look for a certain funding amount, a certain research theme, a funder, a country, or a timeline, you can also organize the grants according to those criteria. Next slide, please. So I just want to highlight some of the gaps that Eva was also mentioning during her presentation. So the current neonatal mortality rate, so this is based on data from 2022, and you can see here that 79% of neonatal deaths are concentrated in sub-Saharan Africa and Southeast Asia. So that's reflected by the darker blue highlighting of the countries there. Next slide, please. And if we look at the map, it's a little bit inversely related to what is currently the reality of the funding to low and middle income countries. So we see a lot of countries who actually have no grants of research funding for them at all. So I think that really the map in this instance really highlights the global geographical burden mismatch and how we need to do better at sort of reallocating funding towards countries that have higher burden and need for research. And this a bit also plays into the gap number 2 that Eva was referring to, which was the leadership shift to low and middle income countries. Next slide. And another key feature, I think, of the map as well is you are able to search by research themes, and you can see some of the research topics that might be a little bit less have focus on. So in this instance, stillbirth was also found to have a lot lower amounts of research themes, of research grants allocated towards it. And in this instance, you can see 12 grants were found within that. So it can be helpful in that sense that you can access the grants that are linked to stillbirth and potentially be a good route to identify collaborators linked to research themes that are less commonly funded. Next slide. And this is just a brief video to also show you the implementation research grants. So if we go ahead to play it. And if we click on Brazil, which has 408 research grants, you're actually able to filter all those grants according to research type. So we filter by implementation research, and then within all those 408 grants, there's actually only 5 grants available that target implementation research specifically. So you can see that this kind of also highlights gap number 4, which certain research types there are gaps in what's available and what is funded in terms of the research itself. So yeah, this just sort of builds on the points Eva was saying about the 4 gaps, and we hope that this will kind of help to reshape the global research landscape as well and can be used as a tool in this sense. Next slide. So just to summarize, it is a great tool to find collaborators for potential new research projects. It also amplifies current research findings that are available, increases transparency and accountability. And then just to conclude, again, we hope that this will really be used to help reshape the global research funding to better match the burden and context, with more focus specifically on implementation research and maybe areas that have been historically underfunded, such as stillbirth. Next slide. And if you would like to access the map, there have been links shared in the chat as well. And you're able to scan the QR code. And thank you to the London School of Hygiene and Tropical Medicine Innovative Funding Competition for sponsoring this map development. Thank you. And I'll pass back to Peter.
Well, thank you so much, Ellen, for that, for showing the power of a map with Dr. Doris Kwesiga, who is going to be making a presentation to us on newborn research around on using the tool for newborn research to map and catalyze change. Dr. Doris.
Thank you, Professor Waiswa. Good day, everyone. Okay, sorry. Yeah, thank you, Professor Waiswa. Good day, everyone. I'm happy to be here. Welcome to this webinar and to this session. My name is Doris Kwesiga. I'm going to speak about, let me just flash my face briefly. Yeah. So my session is around map power, using the toolkit newborn research map to catalyze change. But I shall start by sharing my research story. Next slide, please. Yeah, so I'm a recent PhD graduate. I'm a Ugandan, mostly trained in Uganda, a bit in Sweden, Uppsala. And I'd like to start with this, snapshot about who I am, so that as I talk, we get the perspective of, what I'm saying, put things in perspective. I've worked mostly on maternal and newborn health in Africa, both in health facilities and communities, but mostly looking at using a qualitative approach, various topics, kangaroo mother care, adverse pregnancy outcomes, and that. And I am currently a new postdoc at African Population and Health Research Center, which is in Kenya, recently transitioned there from the School of Public Health in Makerere, which was, home for a long time. So I'm at the stage of broadening networks, farming up my niche in research. Next slide, please. Is the next slide on? Yeah, thank you. Sorry, I think there's a lag. So I'm looking at the newborn toolkit research map from a number of perspectives and how it can be useful to a researcher like me, postdoc, early career research. And sorry, please go back. Yeah, so I'm looking at the map and how it can be useful to me. The first way is looking at my locality, Uganda, and the newborn research map. It shows 18 studies between 2010 and 2024 on newborn research for Uganda. But when I look at it, I'm able to tell who is working on what, with whom, what is the geographical reach in the country, what demographic groups, is it just newborns or mothers as well, which studies are being run by universities, NGOs, consortia. And then it also shows that the research approach, like 7 grants are experimental, 18 observational, only 1 with implementation research. So I feel like when I use the map, I felt like I'm removed from being in a vacuum of knowledge about these in-country studies. I knew only 2 in Uganda, but from looking at the map, I found, 15 others, 15 or 16. And it directs me a bit better to understand what areas are being studied in the country. There was something about COVID-19 and pregnant women and babies. So then I can have that kind of perspective from looking at this newborn map. Next slide, please. And I know who is doing what work. I can go to their websites and see what else I can do from there. Then another way in which I can use the newborn research map that's part of the toolkit is by understanding the themes and topics of study. So again, if I use a Ugandan perspective, this is just one example. Like I can see the various themes that are being studied in Uganda under newborn research. There is congenital conditions, 1 study. Most are on neonatal infections, 9 studies, then stillbirths have only 2. But it's not just about Uganda. I can now also look at, Kenya, where I am. If I want to see what work is being done there, I go to the map. I saw 23 grants from Kenya, 7 of which were around neonatal infections. They also have studies on feeding and nutrition, which Uganda did not have in the map. So what is the point of all this around themes and topics of study? As a postdoc or early career researcher, it helps me to understand which areas are potentially, saturated in terms of study, like neonatal infections. There are so many studies. Those receiving less attention, like stillbirths, and then those which what are the topics for potential follow-up studies that can be done? Next slide, please. Another way in which this newborn toolkit research map is helpful is networks. So we all know the benefit and the advantages of networks and partnerships in research. It's not a one man or woman job. By looking at the map, I was able to find potential partners, and someone else can do so for my area, for your areas of interest. Whom can you link to for further learning? It's shown in the map, the different studies. What are areas of synergy and joint grant writing? You can create in-country partnerships, multi-country, south, north, multidisciplinary and all that. So as an early career researcher, it gives me that kind of entry point. When I'm looking for people doing newborn research work, whom can I partner with? Who is doing what? So the map in this case is a tool to build my networks. And when I build those networks and get into these other partnerships, we can tap into having combined skills, experiences, tapping into each other's networks, working across bigger geographies, and that kind of thing. Next slide, please. So the money, which maybe should have been the first slide, I don't know, it's so important. And so it's about money in research that's going to help us, do what we should be doing and what we want to do. So the newborn research map helped me to understand who is funding what, who are the funders currently, who is funding newborn work, not just locally, but in Africa, across the world. When I looked at it, I found a number of funders that I was not aware about at all. And from examining those trends and seeing the funders, then I can follow them better, see when they issue a request for proposals, what some funders prefer to fund. They may want certain areas or certain research approaches, so then I have better knowledge around that. Some may prefer experimental work or implementation research work. Then is there what I thought maybe was around what is missing, and what I saw was missing was African-based funders, which is, food for thought. How much funding is from Africa or to the rest of the world, maybe in the future. Next slide, please. Next slide, please. Yes, sorry for the lag. It's, I think, network. So the last way in which this newborn research map was of use to me was looking at the research approaches and the kinds of discipline towards research. For example, in the entire map, 549 studies are observational around the newborn research, 658 employed basic science, 70 experimental, only 16 implementation research. So I'd like to, highlight something about the implementation research component, because we know it's critical, especially for resource-limited settings, but there's very little of it being done in this, in our kind of setting. So how does the map help me in terms of implementation research? I can identify colleagues doing similar implementation research work. We can learn from each other, improve our skills, see which frameworks we are using, and have cross-study learning, explore synergies. Next slide, please. And even suggest to identify implementation research areas for ongoing studies. So are there any hiccups with a map? Maybe the one I would want to highlight is that there are certain, it's a work in progress, which is not a hiccup per se. So 1 or 2 studies could be missing, but it's being worked on. Next slide, please. But otherwise, I've generally found it as a very useful tool. And this is, as I come to the end of my session, I would like to just have these final reflections about how we can help researchers across Africa, basing on what I've seen in the newborn research map and the other aspects of the toolkit. There are a number of things we could do, but I'm going to focus on one area, which is funding, the money. So what could funders do differently? They don't necessarily have the answers. Their suggestions. Could funders broaden the thematic scopes that they're funding? For example, stillbirths have much less funding. Can funders consider that? Can we fund more implementation research that is critical and particularly useful in the African setting? Can we allow more local innovations and more homegrown research ideas? So by this, I mean, could funders allow the kind of approach where the African scientists are generating ideas, and then the funders buy into this, rather than usually the other way around? The funders bring out the ideas and then we respond to the RFP, even when it may not be the particular topic that we wanted to do, but there are more local innovations allowed, those African generated ideas, and again, funding from Africans for Africa. Finally, I'd like to highlight the need for more funding towards early career researchers, postdoc people, early career researchers from the African perspective. Sorry, I'm a bit biased, but I think we need a lot more of that. Yes, there's some, but could more be ring-fenced for newborn research work especially. So thank you for listening to me. I'm willing to take on questions during the Q&A.
Thank you so much, Doris. Doris was my PhD student. Now she should pioneer this map in Africa and beyond, and also expand our network. Now we're going to have Professor Joy Long, who will be talking about democratizing implementation research and the Lancet Commission. Professor Joy.
Thank you, Professor Peter, and just such a privilege to be here today with all of you. So in the data that Eva showed from this Lancet paper, around 3% of the total funding is spent on implementation research that we're able to capture. And we'd encourage you to look at the paper and the Dimensions database. So maybe you can go back here to the first slide. So really important to think about implementation research. And here we're not trying to make the case for it. Actually, on the Newborn Toolkit, this was one of the things when we asked people what they want webinars on. This is a common topic. So that's why we've done an extra long one in the lead up to the holidays as a special holiday present for everybody for asking for it. So what I'm going to talk to you about is what is it and how do we do it? So as a researcher, if you're looking for a definition of implementation research, the most cited paper with an implementation research definition in it is this fantastic paper that many of you may have seen by Professor David Peters, used to be at Hopkins. And over the last 10 years since it was published, it's been cited about 1,567 times. And in this paper, as well as giving a definition, he makes an important point that in implementation research, the question is king. So that may be a little bit gender focused, but the question is critical. So I want to try and answer 3 questions together. What is implementation research? Secondly, how can we start? What are some useful tools, frameworks, methods? Where can you go to find out more? And we'll be hearing from a really fantastic talk by Professor Per Ashorn after this about what WHO is doing on that, and also from panelists. And then I just have one slide on, we have plenty of Lancet commissions. Why are we having a new Lancet Commission? And Peter is also a commissioner on that for evidence-based implementation, which is really about democratizing implementation research. How can we do that? So if we go to the next slide, Having found the most highly cited paper, and the definition for implementation research from that paper is here at the top, scientific inquiry into questions regarding implementation, where implementation is an act of carrying out an intention, and then the health research can be about health policies, programs, practices, collectively called interventions. So that actually sounds pretty complicated. And if you look online, there are literally hundreds of definitions. AI gives us this other definition. UNICEF has a number of different definitions, including embedded implementation research. And we'll be hearing from Professor Deborah Jackson, who used to work at UNICEF, about that later. There are also formulas. This is just one, but there are many formulas. So to really boil it down, if we could go to the next slide, let's go back to first principles of what implementation is. So implementation comes from the Latin word implere, and it's to carry out an intention or an intervention into effect. So for example, policies are cheap, but actually implementing costs. And when we think about implementing, we're particularly thinking about real world context, thinking about user-focused design. How do we make this work? And if you click again, on the other hand, when we think of research, this is a scientific process, and particularly how we traditionally think of research is about efficacy and controlled and randomized controlled trials. So if you click again, the stereotype is that the implementation is done by the doer and research is done by the thinker. And the whole principle for implementation research is to think about what we do. That's the simplest definition. So if we go to the next slide, one of the papers that can be really useful if you want to start out on this is this great paper by Jeff Curran about implementation science made too simple. And he talks about implementation as doing the thing. And then research, if you click the next bullet, has studying the thing. And then if you click again, what we want to do is to align those. So implementation research is the study of how best to help people or places do the thing. So I love this, and maybe I'm a simple pediatrician, but to me this makes a lot of sense. So then our next question is, if this is what we're trying to do better at helping people or places to do the intervention well, the already proven intervention, how do we do implementation research? So if you go to the next slide, well, we really have a long history of how to do evidence-based medicine. And if you look at this hierarchy, this is something we will all be familiar with. So at the top, systematic reviews, putting together usually randomized controlled trials. And at the bottom is expert opinion, what somebody says, kind of Delphi approaches. And this is the evidence-based approach. And in the London School, the randomized control is king, actually, not the question. It was something that came from the London School. And I think this applies in Cochrane, it applies in many of our evidence-based approaches. But if we're looking at implementation research, we want to not lose the evidence-based pyramid. But if you click the next slide, if you look at the guidance of implementation research, there are at least 61 theories, frameworks, or models. There are at least 73 different strategies, maybe more. There are at least 400 different measures. And even if you take the most cited paper on outcome domains for implementation research with Proctor, there are 17 there. So this is really quite complex to manage. And of course, implementation research is the study of complexity in many ways. But how do we get going? So if you go to the next slide, to boil it down, the question is, what is your question? So to get going, being very clear on what your question is. And quite often for many of us, that will be a practical question around things that we're trying to implement. And then be very clear on our evaluation design. So randomized controls and more rigorous studies, including quasi-experimental and step wedge and so on, are important for newer interventions or risky ones or ones that need major investment. But if it's a well-known intervention and we're looking at how-to questions, then a randomized control trial is not necessarily the way to go. There are many things that we can do looking on data regarding change, process change, barriers and if we go to the next slide. Thank you. So this is an example of the Nest Alliance, where we're working now with 6 country governments and 22 different organisations on multi-system change. And with that is embedded research with embedded core data that people can use. And that's particularly for driving quality improvement. And that can be a spectrum with quality improvement questions that we then feed into implementation research with a more systematic, theory-driven approach to look at our questions. So if you click the next point, yeah, we have lots of how-to questions. So how to increase kangaroo mother care, how to do it earlier, how to do it for more hours, how to increase respiratory support for preterms, including CPAP, how to close blood culture gaps, how to improve nurse and device ratios. And then a more complex question overall is, if you do this whole systems package, does it have an impact on neonatal mortality rate in hospitals? And is it cost effective? And can we look at input-output analysis using an implementation research framing? So this does require a more rigorous quasi-experimental design, because overall it's going to cost more money and you want to be more thoughtful about the question and to be able to drive bigger policy change and investment. So if you go to the next slide, what about some tips? And so this is the toolkit. We like to give you practical things to do. Well, here are some helpful review articles, and we can post these in the chat and share them after the time. So I've mentioned the Jeff Curran piece. I've mentioned the David Peters overview. There are also websites, and particularly would flag the WHO Tropical Diseases Research Toolkit, where they have, and in fact, if you look at that toolkit, you will see that that toolkit was also a design inspiration for the newborn toolkit. The Re-AIM site, which has really helpful inputs and guidance, including PowerPoints that you can download and adapt. And then there's also training. There's a massive open online course by WHO TDR, and there's a UNICEF one coming soon. So if you click the next slide, just some thoughts on how to get going. Pick an actionable, answerable question. Look for relevant papers that people have already done on that question, so it may already be answered. Look on the Newborn Toolkit, and I just love what Doris said, as an implementation researcher now in Kenya with APHRC, looking at how she can find different topics, networks, disciplines, people locally. Ask others, don't be afraid to ask. Design a doable approach and a doable way to assess that, ideally using data systems you have. And then you don't need to invent a new organizing framework. You know, there are so many. So if you go to the next slide, particularly if you're looking at implementation for high quality small and sick newborn care, really encourage you to think about this fantastic systems change framework that WHO and UNICEF have put together with 10 core components. So 7 of them are health system building blocks and 3 of them are connections along the continuum of care. And that's the basis for this toolkit. So you may find useful tools, things that people have already answered. And we would really encourage you, if you learn something, if there's something that you're learning through quality improvement or through implementation research, please share it and help us to go faster together. So if we go to the next slide, this is the last slide. So just one slide on why a Lancet Commission on evidence-based implementation. So there are many Lancet commissions. And this commission is looking at how do we bring together that world of implementation and evidence-based thinking or research. And really honoured to be part of this with others and a number of people on the line here who are involved. And in doing this, we really want to hear from you. So please do fill this survey, please do share it. What would help you to generate and use evidence in the real world? How do we democratise this? And we really welcome your inputs and insights. So I will stop there, but happy to take questions in the chat and pass back to the fantastic Peter Weisfer. Over to you, Peter.
Thank you so much, Joy, on democratizing implementation research. And the question is king. Our next presenter is Professor Pa Ashon. And Professor Pa Ashon is the new head of newborn and child health at WHO. Is published over 300 articles. Professor Pa Ashon is going to speak to us about the role of WHO in newborn health. Prof, over to you.
Thank you, Prof. Am I audible?
Yes.
Apparently I am. So, first of all, I'd like to say that I'm honored to be speaking among such great presenters. I've really enjoyed my presence here. And I, of course, would also like to acknowledge my colleagues who are shown here, who have shared the data that I will be showing with you. WHO is not a research institution. We are not academics. But if you click next time, you will see that we are guided by science. And if you click again, you will see the 6 functions that United Nations has given to the WHO. And you see there the shaping of the health research agenda. So we are a normative agency that tries to support our member states, but uses science for that and sets the research agenda to know what are the important questions. So therefore, we obviously want to be involved in research. But if you click next time, we don't want to be involved in all kinds of research, not all newborn research, but selectively on research that can support the guidance development, country support, or other WHO activities like monitoring progress. And there are 3 different types of research that fall under this aim. And the first of is what is the focus of today. There's often new guidelines coming out of WHO, and people say, okay, it's those Professor Ashons and others who sit in ivory towers and make recommendations that we cannot implement. And the question, like Joy was saying, is how actually do you implement those? And that's a set of questions that we are nowadays addressing more and more. The second one is typically there's some new information coming from high-income countries, which is probably would be useful also in low and middle-income countries, but there isn't research there, and there's a sort of a need to fill in that vacuum, and that's another set of another type of research where we could be involved. And the third one is then that there are sometimes projects that would be a bit difficult for others to do. For instance, because they go against WHO current guidelines. And then we might enter into the research. And in the next slides, if you click next, I want to give you examples of all of those, starting now from the implementation research. First example comes from the use of antenatal dexamethasone. If a woman is about to deliver a baby too early, and we are worried that the lungs will not be matured, there's a possibility that you give dexamethasone to the mother. And there was a study published by the so-called WHO action trial collaborators that if you have a situation where there's an early preterm baby about to be born, giving dexamethasone 4 doses markedly reduces the neonatal mortality. And therefore, WHO issued guidelines on this, that this would be a useful thing. But there are several problems. How do you know that this is an early preterm delivery when so often you don't really know the duration of pregnancy? How do you not give it to the older ones? How do you manage possible side effects? How do you reach the recommended 70% coverage, and so on? So if you click next time, WHO with collaborators from Bangladesh, India, Ethiopia, and Nigeria have started an implementation research project that has 4 different phases. And these are what what Joy was talking about. There's a pre-study phase, which is a desk review where you look at what are the current policies, what data do you have, what perhaps capacity for small and sick newborn care the country has. Then once you know that, you go into a formative phase where you actually now go to where delivery of care happens, and you look at what are the people available, what are the current practices, what could you possibly modify. Once you are there, you go into the sort of a 6 to 9 month, whatever period, where you go through iterative cycles of improving the model, how you want to deliver the things. This is the way we want to estimate the duration of pregnancy. Here's how we give the drug. Here's how we manage the weekends and so on. And through that iterative cycle, and in this case, you do those iterative cycles in 4 countries, you come up with the final optimized delivery model. And then you take that into what is called a step wedge trial, where you evaluate the impact of that final model on both the coverage of the care and also on neonatal mortality. And the step wedge design is shown here. Basically, you slow in stepwise, you take one area at the time into the intervention. For instance, 3 months you use it only in one area, then 3 months, the next 3 months you use it in 2 areas, and so on, going on, so that in the end you can compare the time with the old system and with the new system, and you get also an assessment what the neonatal mortality reduction might be using this specific model. And the same system, if you go to the next one, then we have used, or we, other research groups, have addressed on kangaroo mother care. You know that in 2015, there was a recommendation by WHO to offer kangaroo mother care to all babies below 2 kilos who are stable and can be managed in hospital. Thereafter, there have been studies showing that you can actually start it in the community, shown here on the left, or more importantly, you can actually deliver it immediately after birth for babies who are from 1 kilo to 1.8 kilos. And this, again, would be quite difficult to think, how do you deliver when you do the immediate care? Because it will require the conversion of the neonatal intensive care units to family units somehow. And if you click next time, you will see that there's now a recommendation to do this, and then click again, you will see a description of an implementation research that is now going on. Again, this is in Bangladesh, India, Ethiopia, and Nigeria. And again, it has a model development phase, which in here is almost 2 years. And we expect to finish that in the 3rd quarter of 25. And then again, we would end up into this step wedge evaluation. And like Joy was saying, these are studies where you already take for granted the efficacy of the intervention. And the question is, through these repeated cycles where you see the pictures, either bedside or in classroom, you evaluate, what could we do better? How do we modify? And things like that. Let's go to the next one. I have another example, then I go to the other 2 types of research that WHO is involved in. This one is an interesting one on the use of probiotics among preterm or small for gestational age infants. The use of probiotics is actually recommended also by WHO for preterm infants. The data comes mostly, and it's used mostly in high-income settings, whereby you're trying to reduce the incidence of necrotizing enterocolitis, NEC. And but there's a belief that it also would reduce sepsis and mortality. So now there's a study that is going on in 5 countries. In this time, it's Bangladesh, Pakistan, Kenya, Ethiopia, and Nigeria, where you take a group of preterm infants or a group of small for gestational infants, randomized then in getting 4 weeks of probiotics or placebo, follow up 6 months, and look at the incidence of NEC, sepsis, and mortality among the preterms, or NEC, sepsis, and underweight-free survival. And again, the aim is to see if this is something that could be used in low and middle-income countries as well, and we could write guidelines on that. Then the last 2 studies that I'm going to show if you click next time on the last question. So items that are difficult for others to address. I already showed you this WHO recommendation on the use of antenatal corticosteroids. That recommends the use for early preterm babies or for women who are about to deliver an early preterm baby. There was a concomitant study going on actually for late preterms as well, called the WHO Action Trial 2. And it was supposed to be a multi-country trial. It started in India, enrolled slower than planned, and the mortality was much lower than planned, and it was stopped for futility. And when WHO trial was stopped for futility, others have been hesitant to take up a similar trial. And therefore, WHO has taken it. Click the next time, you will see something called Action 3 trial, which is now focusing on high mortality areas, high mortality populations in Bangladesh, India, Pakistan, Kenya, and Nigeria, about to enroll 13,500 women, and this time using 3 groups, the placebo and dexamethasone that have been used earlier and is recommended for the early preterms. But there's also a group that receives betamethasone and a lower dose, with the thinking that the dexamethasone probably is too high or an unnecessarily high dose and causes hypoglycemia and possibly causes developmental problems in the children. So there are sub-studies looking at those outcomes as well. And there will be an interim analysis done very soon. And then all the results are expected to be out in December 2026. And the last slide that I wanted to show of the studies is the next one, which is now a very contradictory study where that is called the branch, where the question is in low and middle income countries, in areas where occasional use of milk formula under 6-month-old infants and where growth faltering is common, can you actually do something, improve outcomes among growth faltering children by giving them supplementary milks, which goes against the so-called breastfeeding code. And this is a 7-country trial. You see all those, and where infants are recruited soon after birth, they're given very extensive guidance on how to do exclusive breastfeeding. If there's a concern about growth, they get more of that guidance. They get guidance on how to extract breast milk and give that in a supplementary way. If after 2 months they are still undergoing growth faltering, then you actually start giving supplementary milk formula. And then at the age of 6 months, you look at wasting-free survival. This study has recently started, and we expect to have the results in December 2026. So those are the different types of research, and implementation research is very important that we work on newborns. And you can go back to the slide that you already started. All of them are aiming at producing guidelines that we could then provide to the member states. And click next time, all of them use an approach where a funder has, like the Bill and Melinda Gates Foundation or others, have approached the WHO. WHO has put together a research consortium. The research consortium has done the work, and then click next time, WHO actually makes the guideline. Now, this has been a typical model, but you already clicked the alternative model that I'm now sort of trying to market, that if you do trials and you want them to influence WHO guidelines, you can actually, and the funders can approach directly research consortia, and research consortia can contact us, and we can come in as a sort of a regulatory monitor like Food and Drug Administration does for pharmaceuticals when you want to license them, that we are involved at the beginning in thinking about the study design and what are the important outcomes that we would need for issuing guidelines. And then somehow we are involved in the monitoring so that at the end, we know that this is a valid question, well-done study with important outcomes, and we can write the guidelines. And then if you click once more, there's an intermediate where actually there are funds going through both directions, and we are more involved in also somehow the implementation, like thinking about the tools that could be used. So all those models are there for you. And I would now like to hand it back. We can call them level 1, 2, 3 participation. And the last slide is just to thank you and thank all the participants in the KMC studies. And thanks for the attention, and back to Peter.
Thank you so much, Professor Ashon, for showing us the defined studies and the role of WHO, special studies to inform guidelines. Now we are going to be moving to the panel, which is the last 30 minutes. For those of you who have questions, please continue putting them in the chat, and the panelists will answer the questions. Our panel is the next 30 minutes, and we have 4 panelists. Now, panelist number 1, as you can see, is Professor Abiy Saif, who is an associate professor in Ethiopia, Addis Ababa, and has been doing a lot of newborn research. He's also leading NEST work in about 290 hospitals in Ethiopia. Then next is Professor Deborah Jackson, who is a professor at London School of Hygiene and Tropical Medicine. She's also the chair, the Turkish chair in Global Health, and also the deputy director for the Mike Center, which is based at London School of Hygiene and Tropical Medicine. Deborah was previously at UNICEF, where she was pioneering work in implementation research. We also have Dr. Cecily Fadel, who is from the Gates Foundation. Cecily is the senior program officer, newborn health, at the Bill and Melinda Gates Foundation. She's also an attending neonatologist at Harvard Medical Faculty, and where she also teaches. And then finally, we have Dr. Minnie, who is Minnie Chibole, is a pediatrician and public health specialist with over 15 years of experience. She's the senior manager for child health and development at the Children's Investment Fund Foundation, and responsible for that portfolio. We'll start with a presentation from Abiy. Each of the presenters will have about 5-6 minutes. Over to you, Dr. Abiy.
Can you hear me?
Next slide, yes.
Can you hear me?
Yes, I can hear you. Thank you.
Thank you so much for the introductions. I don't have a slide to present, but I will speak on, I think, the question around,
Yes, sorry, for the question, yes, please. We want to know from you, in terms of your experience in Ethiopia, some insights on implementation research and the enabling local tech leadership and the building relationships. So your experience based in Ethiopia.
Yeah, thank you so much, Professor Peter. So maybe I will share some experience from Ethiopia, our team. So to introduce myself, I am Abiy. I'm based at Center for Implementation Sciences at the School of Public Health, Addis Ababa University. I'm, coordinating a consortium within Ethiopia that is conducting several implementation research projects and also supporting the ministry to scale up level 2 sick and small newborn care in partnership with the NEST 360 team. So in terms of implementation research, our team has been engaged in conducting implementation research since now about 10 years. So the evolution has been very interesting experience we had. So one thing I could mention in terms of implementation research is partnership. So we have a strong partnership among academic institutions based in Ethiopia, and of course led by the government, including the Ministry of Health and Regional Health Bureaus. And we have very strong and long-lived partnership also with partners like the World Health Organization, some of the research projects that Per has mentioned earlier. We are also part of that multi-country implementation research. And then we have strong partnership also with UNICEF. And we have partners, based in US, UK, and EU. And we have also close partnership with donors, including the Bill and Melinda Gates Foundation, CIFF, ELMA, and USAID. So, that strong partnership is a foundation to, creating that environment to do implementation research. Of course, the need is driven by the government. And then I think the other important aspect is a co-design process. The request comes from the ministry and the regional health bureaus, and sometimes from our own experience. But we sit together with key stakeholders, including the ministry and all the partners I mentioned earlier, but more importantly with facility managers, frontline healthcare providers, community groups, and mothers and families. We really take time to identify the key barriers of not getting these evidence-based interventions into babies and mothers, and what are the strategies we have within the context we are in to get those solutions to the people in need. So that co-design process is very important in implementation research. The other is continuous iteration. We apply a deep reflection driven by data. And we also question some of our assumptions. When we design something, we hold some assumptions, including the health system readiness and the motivation and the commitment by different stakeholders. So we reflect on them, and then we make changes to our assumptions and approach. So that the ecosystem can allow us to implement the newer strategies. And then the other important aspect is we also do embedded program learning and evaluation. So like Per has mentioned earlier, some of the implementation research, if you want to complete the whole cycle, they could take between 3 to 5 years. But we cannot wait until that learning is documented and published to get evidence-based solution to the people in need. So that continuous learning through qualitative and quantitative data and rapid dissemination of the early learning, so other people who are operating in the space can replicate some of the effective solutions, is what we are applying. So, but we also continue our rigorous evaluation of the implementation, the intervention in the models. The other important aspect is local capacity building. So I am based at Addis Ababa University, and there are more than 2/3 of faculty members across the universities that formed our consortium are young people, and they have a lot of capacity potential, but they don't have opportunity. So this implementation research creates those opportunities for them to learn, and also we create capacities within the ministry, regional health bureaus, health facilities, and communities. And the capacity that is built and retained in these institutions are really useful. I have been working for the past 12 years in newborn maternal health space, and I have seen 6 ministers of health and 6 newborn health coordinators. So, but I am still there. So that institutional memory and capacity we create in these institutions are really, really very useful. So I will pause there, Peter. Thank you.
Thank you so much, Abdi. Thank you for that experience from Ethiopia. I think the same in Uganda, and it's what we need across Sub-Saharan Africa. Next is going to be Deborah Jackson. Deborah is going to be speaking about insights on approaches to embedded implementation research with examples from UNICEF and maybe how we can democratize research. There are some examples. Deborah. Deborah Jackson. Deborah Jackson, are you there?
Maybe you can move to Cicely.
Maybe
first.
as we can go to next to Cicely, maybe Cicely from the Gates Foundation.
Can you hear me now?
Okay, Deborah, we can hear you. Thank you.
Okay, great. It was the headphones. I'm sorry. I put them on for my mates, my office mates. Okay, so UNICEF. I mean, I think it's really great. Thank you to the previous speakers. It really set me up perfectly. You know, Per talked about WHO is not a research institution. Technically, though as you can see, they do quite a bit of research. UNICEF is even less of a research organization. UNICEF is about boots on the ground and implementation. And so really, I love those graphics where he said, you know, everything goes into creating those guidelines. And really where UNICEF then takes it on is, okay, we're going to start with those guidelines. Now, how do we adapt those guidelines into these contexts? And so as people have said, Joy said, it's real world. So it's not controlled trials or study conditions, though it can be part of controlled trials. It's generally not. It's real time. And I think that's in the way UNICEF works, it's often in real time for improvements within a program or a policy cycle, which happen every year or every 2 years. So you want answers so you can make decisions. It documents how, as Joy said, and I think as Dr. Abi said, it's demand driven. It needs to be identified by implementers. And I think for UNICEF, the key is that we cannot do implementation research without implementers. Preferably it's embedded, as we said, and it's led by the implementers. That being said, implementers, program managers, district managers, they don't have time to do research often. And they'll look at you like, I don't have time for that. But what you can do, and what UNICEF tries to do, is pair them with local researchers. So even though I sit at London School, or at the time I was sitting in New York, we wanted them to pair with local researchers like University of Addis Ababa, and actually Ethiopia has been a long leader in implementation research across all of their universities. So you need to pair with those local colleagues, because that helps also the local implementers build a relationship with local researchers, which can then continue. And I think Dr. Abi talked about you start with the challenges. What are the implementers' challenges in making this program, say a WHO guideline, work in their situation? And if they know what the problem is, and they know what to do about the problem, then that's a management or a quality improvement situation. If they don't understand the problem, or they understand it but don't know what to do about it, then that's an implementation research question. So implementation research is part of your entire program cycle, from formative research up to end-line evaluation. And Stefan Peterson, a former head of health at UNICEF, used to say that implementation research is like fixing the plane while you're flying it, as opposed to waiting till the end-line evaluation crash when you find out it didn't actually work, and you spent 5 years and $5 million doing that. So when I talk about time, and I think, you know, Dr. Abi mentioned, you know, that these things need to be more timely, we can't wait. And I'm going to give you just a quick case study of a project, one of my favorites that we did in UNICEF. And this was in Malawi. It was around prevention of mother-to-child transmission in adolescents and supporting pregnant adolescents who are HIV positive. And the Ministry of Health in Malawi was wanting to expand their PMTCT program to have specific adolescent programming. And one of the programs they had was mentor mothers, so mothers helping, the mothers who had already gone through the program, and then helping mothers who are now in the HIV positive in the program. And they wanted to know, how do we adapt that for adolescents? Do we need to adapt that for adolescents? So, we went and the UNICEF colleagues and the country office and myself, and we met with the ministry colleagues. We met with the Mentor Mothers program colleagues, and we sat down and we said, okay, what are your questions? What do you want to know? The ministry wanted something slightly different for them from the program, but we basically worked it out so that, the implementers were asking the question that everybody wanted to know. As Joy mentioned, the question is king or queen or whatever, empress. And basically then from there, we were able to write a protocol, get it approved by ethics, get the study done, get it presented at a conference, and then implemented new changes in the program in 6 months. We started in July. By August, we got our ethics approval. The research was presented at a African AIDS meeting in December, and in January, the Mentor Mothers program initiated Adolescent Champions. We had basically a very simple question. What do adolescents want? Mentor mothers who are the same as them, adolescents, or do they prefer older mothers because they feel like older mothers have more experience? And the question is it's a pretty simple question. So we just asked one question. We learned a lot more than that, because once you start talking to people, you learn a lot more about it, about their situation and their challenges. But that was the basic question, because the program wanted to know if they were going to initiate an adolescent programming, do they train adolescents or keep on with their current mothers? And in the end, the answer was they preferred peers. They preferred adolescent peers. And so the program started an Adolescent Champions program. Now, what was very important is that the program hires new people, new mentor mothers every January. So we started in July, and we knew that we had to get this within the next program cycle, because if we didn't, it would be another year. And so you have to start to think about those things, getting them done in a short time. This stuff doesn't cost a lot of money either. That whole project costs $15,000. At UNICEF, our projects generally ran anywhere from 6 to 18 months. And they cost anywhere from about $15,000 up to $50,000. And so because they were trying to fit into, and they averaged about a year and about $25,000, because often they were trying to fit in. They had a question, say, from their current planning, what should we be doing about this? And then they would ask the question and try to get the answer by the next year when they were doing the next planning. For some reason, my stopwatch stopped, so I'm going to assume I'm way past time. But it's basically real world, real time, not expensive, but it's all about what the implementers need. Thank you.
Thank you so much, Deborah. I like the amendment and the real world, real time, and not expensive. Well, we shall discuss that maybe. Next is going to be Cecily, who is going to be talking to us about the Gates Foundation. The Gates Foundation has been leading in actual funding for newborn research and also implementation research. Why has the Gates Foundation done more than others, as we saw in the data? And given this burden of disease that was presented, the funding is still relatively small. What would help to make the case for more funding? Ceci?
Hi, thank you so much for inviting me to speak on this important topic today. So yeah, it's an interesting reflection of why there's such an emphasis at the Gates Foundation on stillbirth. I think it may be in part because, there's a spectrum of different technical experts that work at the foundation, including clinicians, who attempt to take a holistic view. And so really, if you take that holistic view, the important piece is to support the mother-infant dyad so that they are allowed to thrive, and that you avoid the triple threat of maternal mortality, stillbirth, and neonatal mortality. And I really think you need to have those things travel together, because on an individual level, these are devastating events for families. And the distinction between, for example, a late pregnancy, stillbirth, and a neonatal death is non-existent. On a population level, in terms of language that financial impact metrics that government funders and other funders speak, there is a chronic undercounting, particularly of maternal mortality and stillbirth, and so they're just not included to the same extent in the metrics. And so for that reason, have in some instances been less emphasized when it comes to research spending, to healthcare spending, in order to make an impact. But really, I think part of making the case for more funding is appreciating that this chronic undercounting is happening, and that you can really get a great return on investment by protecting this maternal infant dyad and ensuring positive outcomes for them. And so one of the kind of focused research areas is at the foundation is trying to understand stillbirth. And so following along with mothers throughout their pregnancy, and then doing a deeper analysis on who is the population that is more prone to stillbirth. To what extent is it health systems? To what extent is there, pathology that's going on, placental pathology, that makes you more prone to this? And it's starting to yield some interesting data that we're following up on to try and get at ways to mitigate or to prevent that specific outcome. And to the question of sort of relative funding amounts, so the Gates Foundation up until recently had been in a phase where there was an ever expanding scope and an ever expanding budget, and so now we're getting into what's going to be a steady state payout. And so one of the shifts in mindset for that has been sort of reframing it, not so much as a zero-sum game, where if you're spending more here, then it's taking away from there, and should you be shifting money over from here to there, but more on how can we bring others along and expand the amount of funding that's going into these critical areas, right? And so instead of trying to do more with less, how can we do more with more, and also create some pockets of funding that are a bit more sustainable? And I think that's where building the investment case can go a long way.
Yeah, thank you so much, Cecily. I think you said it is doing more with more, and to bring other funders on board, and you talk about the need for the investment case. I hope we have one for investment case for newborn research. I mean, there have been many research agendas, but that will come. We'll hear from Dr. Minnie Chibole, who I already introduced. And Minnie, CIFF is the largest private foundation focused on child health and tends to fund implementation rather than research. Do you see scope for overlap, and how does your localization strategy enable more low middle income leadership? Minnie?
Thank you, Peter, and thank you so much for inviting me to this conversation. Very important, very vital, very close to what we do at CIFF, because we are, like I said, Peter said, the largest private foundation funding child health, but specifically, we work across maternal, newborn, child health, and with a real focus on newborns because of really the stagnation of gains over the last decade or so, and particularly in Africa and South Asia. So I would like to talk about, we mostly fund implementation, that is true, and really to say that we are also a research-focused organization in the sense that we believe there's a lot of overlap between implementation and research. The focus on implementation is primarily, and really, when I say overlap is we embed a lot of research in our implementation. So we believe truly that there's a lot of evidence-based interventions out there that have been proven to work that are really not delivering or not being implemented at adequate scale or with adequate efficacy to deliver the impact they're supposed to deliver on the ground in a real life setting. And that really is the focus of CIFF, is to, as we implement programs, for example, newborn health programs like Nest 360, is to ensure that as we implement the programs, we embed implementation science so that there's continuous learning, there's continuous improvement, and also continuous sharing of lessons with a broader global, regional, national community or country at a country level, so that those learnings are actually implemented as we move on. So like I said, instead of waiting for a long period of time and for an publication to be made before we can actually recommend certain things, is to bring those evidence-based interventions, make sure that they're being documented, and make sure implementation is being documented in a real life setting, that lessons are being learned and being shared broadly. We completely believe in bridging this no-do gap. I think it's a huge ask where we have really great evidence-based interventions and very little implementation actually happening. And governments are always seeking to partner to be like, okay, we know this, we hear this intervention works, we know this intervention works, but how do we actually implement it and ensure that it delivers impact? So alongside our investments is to ensure that the work that we do is also rigorously evaluated, and we're able to demonstrate that in this real life setting, we actually are able to demonstrate impact with all the challenges, whether it be health workforce, infrastructure, and all the other challenges that we face in the low and middle income settings. So that's one thing I want to highlight. The other thing is that we really believe in in hearing the implementers' voices and hearing from them what works. So for example, like the support we're providing to the Lancet Commission on Evidence-Based Implementation, that Joy and the rest are involved in, is to really hear the implementers' voices. They're the ones on the ground, they know what works, what hasn't worked in their setting, and we can bring all this together in a scientific way to actually inform the global community on how they can actually implement certain interventions. The other thing I want to speak to is really about how we also are supporting, within that context, is supporting early career researchers like Doris, who spoke earlier, so that in the context of such programs, like NEST, for example, is where we have maybe early career researchers and they are supported or partnered with more established researchers and able to build their career within the research, within the program. And you know, of course, and these are all for the researchers and the implementers as well, so that we can actually build that local capacity and build the country capacity to do the research and to implement and to actually share those lessons. On the localization, I'll speak briefly about that. We really believe that we cannot develop the low and middle income countries if we do not fund LMIC leadership. So we've started by walking the talk. So at CIFF, we have completely devolved decision-making to the settings where the implementation is actually going to happen. So if it's Africa, we've devolved the decision-making to a CIFF Africa team. If it's India or Asia, we've devolved that decision-making that way, because we believe the contextual knowledge and understanding of that, of the challenges of the environment and so on, and the decisions that would be best suited for that environment would best come from the actual local implementers themselves. So we have started we walk the talk, we have devolved our decision making, and we are supporting local organizations to really build up their capacity so that they can be able to be leaders in this field. And to do so, we have, for example, we partner with, because we may have organizations that are not so established or may not have such, in terms of capacity to absorb certain funding, is we partner with them as strategic partners. We support them through organizational development and so on multiple areas. And we build that capacity so that we work hand in hand with them to the level whereby they're able to actually implement larger grants and be leaders in these fields, especially in fields that are really challenging to us, such as newborn mortality. So we walk the talk, And our portfolio, for example, has really expanded from more less than 30% local organizations to almost to 70% now. So partnering strategically with them and building capacity. And like I said, pairing with more established organizations and partners to ensure that we build the capacity. In 10 years' time, we want to be able to say we have local capacity, we have built a country capacity. Thank you.
Thank you so much, Minnie. We're almost out of time. I think there is room for one question from me to all the panelists, maybe two. If one is, which way forward having presented, because I'm sitting in Kampala and I don't see money for newborn research. I don't see money for implementation research, but there's all this talk around localization, etc. One way it is happening, then also for how can we do implementation research that facilitates scale? I think those are the needs of program people. Who would like to have a go? Professor Joe, you like to answer this, or anybody?
I think somebody else should speak.
Okay, so yes, anybody would like to comment?
I can speak to the first question, Peter.
Yes, yes.
It's unfortunate Uganda is not been one of our focus countries thus far, but that is going to change. So you may be seeing some funding coming along your way. But we do believe in supporting within the context, like I said, of programs. So as we implement programs, really supporting the implementation science, implementation research within the context of those programs. So may not be entirely funded as an independent research grant, but within that context to see how you can be supported, how we can support researchers as well.
Okay. Anybody wants to have a last word before we close?
This is Deborah. Hi.
Deborah, yes.
Hi. I think it's what Minnie said and what people and Cicely is that funders are starting to recognize the importance of implementation. Even basic science researchers like Wellcome Trust, like the Takeda Pharmaceutical Company, they're realizing that they do all this great early science and then they put it out there and it doesn't get where it needs to be. I think the key is partnering with all funders, having them start to understand, and that's something WHO, UNICEF, and various groups are starting to work with, even programmatic funders as well as research funders, to speak about the importance of implementation science. And I think that it's emerging, but we have to keep reminding people so that they realize it's not just basic science, it's also implementation. Thanks.
Thank you so much, Deborah. So I'd like to thank all the panelists, all the presenters, and all the participants who attended. We need implementation research capacity with a focus on newborn, stillbirth, and of course, maternal health and more, especially in low-income countries. And we need to fund it. Also, low-income countries need to finance research